U.S. is experiencing some massive, devastating outcomes within the healthcare ecosystem. Over 110 rural hospitals have closed their doors within the last 10 years, and more than 700 more are currently on the verge of doing the same. And really, the key driving factor of all of this is that after a hospital closes, the death rates within those areas, within those patient populations, rises 6% after each closing. And the reason for this is there's a massive disparity between actual medical provider availability and the demand for these providers. And the actual traditional systems in place, these staffing agencies, headhunters, and recruiters, are inefficient. They're antiquated, they're time consuming, and they cost hospitals billions every year. And their inefficiencies cost America about 45,000 lives each year. And doctors want to help solve this problem. So do nurses, other healthcare providers, and they do this through a thing called moonlighting. So on the days, nights, weekends that they have off and free from their normal jobs, they will go out and pick up other shifts at local surrounding hospitals. However, that current process to find those jobs, get onboarded at them, is very inefficient. It's them driving directly to these hospitals and locations, filling out pen and paper applications, waiting for a 4 to 6 week turnaround just on the credentialing process so they can actually begin working there. And then the actual staffing agencies, these third-party services, are retaining a lot of the earnings, taking away from the providers and gouging the hospitals for this money. My name is John Lensing, and I have experienced these problems firsthand during my 4 years of medical school. I saw patients drive 4 to 6 hours one way just to get the care that they needed. Because that care wasn't available at their own home hospital, doctors left those areas or they just didn't have the specialists available for it. And oftentimes they would prolong their needed medical visits, just pushing them off farther down the line so they would come in sicker, and that would end up resulting in more costs and medical expenses down the road. So we set out to fix this problem, and we spoke with many hospitals asking about their staffing issues, and spoke with hundreds of physicians asking them what is the reason why we can't make this an easier and simpler process. And we took what they said and we began to build out exactly what they asked for. And so Apollo is building out a mobile provider workforce. Internally, we call this our cloud clinic. We are essentially offering start to finish services as a functioning clinic without a physical brick and mortar location. And we do this through one-time credentialing. We pre-gather all of their information. We get our providers set up with insurance payers so we can bill on their behalf. We offer start to finish services, including their medical malpractice, as well as actually billing providers on their behalf. And then from the hospital standpoint, they want to know that they're getting quality doctors. So using our vetting system, we can provide them with unmatched peer quality providers. And then we can automate and save a lot of time and increase efficiency by matching these physicians and other medical providers directly with hospitals that have temporary job needs. And we do this very, very simply through our Apollo platform. Providers can go and enroll very quickly. They post all of their credentials, their CV, their medical licenses. They can post their case logs, house their personal references that's stored in one digitalized wallet for them. On the flip side, hospital setters can go and enroll, and then any temporary job need they might have, they can go and post very quickly in a matter of minutes. They can tell us that, oh, we need an ER physician for the next 2 weeks because ours is going on vacation. Or we can't afford a full-time heart doctor, but we need one in clinic 1 day a week because we have enough patients to meet that kind of demand. So any temporary job they have, and then our system will actually use our algorithms to analyze all the providers in our database against the criteria of that job and then match them up with the same providers that have the same availability, the desiredness to travel to that location, the same pay rate, as well as a whole host of other criteria. And then we really just facilitate that introduction between provider and hospital and allow them to start interacting with each other directly from there. The match process, once a match has been made and once a provider actually works a shift at a hospital, this prompts an internal review. So provider reviews the hospital reviews the provider. These reviews then get compared against their profile preferences that were started at the very beginning. This generates a compatibility score, which is then fed back into our algorithm so it learns, it gets smarter over time to make better fitting and better quality matches to increase job satisfaction and decrease provider turnover in certain areas. So how does Apollo generate revenue? It's a very interesting business model. The current competitors in the space, the staffing agencies, operate purely on a commission basis, and they're taking in between 35 to 70% commission. So massive margins on their end. Because we take a different approach and essentially have set ourselves up as a clinic, we enroll providers as contractors, we provide their medical malpractice, we bill on their behalf. We actually generate our revenue directly from reimbursements from insurance companies. So on average, a physician will work 41.5 hours per month in a moonlighting setting. So just temporary work in addition to their normal 9 to 5. And they will generate an average of $132,000 annually in total billables. And that's collectible billables. Of that margin, the hospital collects 26,000. We would collect 106. After we subtract out their salary, an outsourced billing service, and medical malpractice, we're left with about a 25% profit margin on that reimbursement rate. This equates to about $33,000 in monthly revenue per hospital. And if we can acquire 700 hospitals over 5 years, that's roughly $315 million in total revenue over the next 5 years. Of note that 700 hospitals is roughly 10% of the overall hospital market within the US. But more specifically, 700 hospitals is half of those hospitals that are designated as critical access hospitals, meaning that these hospitals have less than 25 inpatient beds, and they are federally subsidized institutions located in rural areas and are there as a primary reason to serve underserved areas, very rural areas. So these are our primary hospital customer demographic that we are targeting. This slide just goes into our approach for sales and raising awareness. However, along the bottom here are already current partners, including everything from nursing homes to community health systems like Audubon to very large health systems like the University of Missouri. The team here, we're a relatively small team, 3 co-founders. 2 of them are medical school graduates. Third co-founder has a lot of technical experience, worked at Anheuser-Busch for 3 years before joining the team. Curtis Olson, our CTO, is a full stack engineer who has worked at 5 different startups. Tom Gedkin, our CFO, the former CFO for ACT as well. And then while we are a young and inexperienced founding team, we acknowledge that, and we have made it one of our critical missions to surround ourselves with people who are very knowledgeable and have years of industry experience behind us. So Dr. Richard Ferguson, the former CEO of ACT, is our board chair. Jeanette Whirling helps us out with all of our credentialing for our providers. Dr. Brent Cook is a facial plastic surgeon who did about 20 years of moonlighting. Bruce Guy used to work for one of our competitors, was the head of physician recruitment for the largest healthcare staffing company. And then John Courtney, one of the COO for one of the largest health systems in Florida. So currently, we completed our first pre-money raise in February, raised $500,000 from local angel investors. That gave us a 14 to 16 month runway. Due to COVID, we actually scaled up a lot faster than we had initially anticipated. We had to bring on additional team members. We brought on a lot more hospital clients than we had anticipated. And therefore, we plan to go out and raise another round here starting in Q4, late Q3 of this year, which will really help ignite the fire for our exponential growth. Thank you.
All right.
Any questions?
Yeah, go ahead and if anyone has any questions, feel free to speak up.
Hi, John. This is David. I was wondering if you could speak a little bit about how you plan to stay ahead of your competition, and what do you see currently as the greatest vulnerability that you have in the marketplace?
Great question, David. Defensibility is always a very big issue. I could give you the very stereotypical response and say that our matching system, we have a provisional patent on it, but we all are well aware that software patents are very hard to enforce. Our biggest thing right now is that we believe we have a 9 to 12 month lead time compared to our competition in this area. And then we also bring quite a bit of domain expertise to this spot. And I think that actually the 2 biggest components of our defensibility is, one, the layers of complexity that it takes to actually build out a cloud clinic model where we can physically drop a provider in a location, have them working. requires so many different pieces of the puzzle. It requires contracting with payers, which we've already set up. It requires credentialing experts that can get you set up within those payer networks and get your primary source verified. It requires a certain kind of medical malpractice that you have to work directly with an insurance agency to set up a very unique policy for this. So those layers of complexities really are not something that a lot of our larger staffing agency competitors want to try to pivot and get into, because it's such a nightmare and headache right now. We're nimble and agile enough to do that. And then lastly, the biggest component to our defensibility is the retainment of our talent pool. So with our providers, if we can control the talent within a certain region, that will force hospitals then to use our system. And we think that we can build a better product and a superior service to make physicians want to stay in our system, because it's such a headache to jump between different competitors.
John,
Go ahead.
this is Greg Barkus. So did I hear you right that you, rather than be a single platform between the hospital and the doctor, that are you now going to represent the doctors? Could you?
Yeah, it's a great question. And this, for background for everybody else here, Greg and I have worked with each other in the past. He led an innovators workshop that I was a part of when we first had our idea. Greg, yes, that is actually the current business model, the former one that we spoke about that we are operating under right now.
Okay.
But the real issue, so we were just a matching service. We just placed physicians with hospitals and allowed them to take care of the rest of the services. The biggest issue with that is the time constraint happens after we've matched them with a hospital. Because after the hospital has said, yes, we want to use this provider, it takes an additional 4 to 6 weeks for them to get all the paperwork done, get them set up with insurance payers so that they can bill on their behalf. If we as a clinic are already able to do that, set them up beforehand, we can drop the provider in a location and have them working within 2 hours rather than that 6-week turnaround. So for hospitals, that's a much better service and a much better offering for them. So that's the reason why we're stacking on all this complexity, because to them it's a much better product and it's a much more marketable service.
Yeah, that's a great pivot. I appreciate the pivot and what it does to your whole go-to-market strategy. So congratulations.
Thank you.
Hey, John, just a clarification on your target market. You're saying the rural underserved. Are you referring to like the community hospitals?
Yeah, so community hospitals would be our primary target. Those that are designated as critical access, that is a specific federally designated classification, which means that they have 25 inpatient beds or less. So the smallest of the small hospitals, they usually have the biggest need for temporary workers and are oftentimes turning to outsourced third-party vendors for this kind of work. Expanding that a little bit more, we are targeting hospitals in general that are just less than 100 beds. So university settings are not really on our list. Large health systems, not really on our list. Urban centers, not really on our target list.
Excellent, thank you. And then just real quick, is the word of mouth approach your only method of expanding your market? Because as you mentioned, COVID, there's a lot of, it would seem, in healthcare, there's a lot of opportunities that come up very quickly. And I would think that word of mouth might actually be one of the slower ways. I mean, good news travels fast, but
yeah,
big market.
Yeah, no, that's a great question. Because we are a marketplace service, both on the B2C of the provider and the B2B on the hospital side. Pre-COVID, our biggest acquisition strategy was actually word of mouth on the hospital side, the B2B component, just because the administrative group are a very small, tight-knit group and they know all the other hospitals surrounding them. However, during the COVID pandemic, we really leveraged a lot of strategic partnerships and alliances. So we partnered with 20 different state health departments that allowed us to integrate with quite a few hospitals. We partnered with every state hospital association, including the American Hospital Association. We partnered with every state medical society and state medical board. We leveraged partnerships. We had Southwest Airlines. They were flying all our providers for free across the country during the pandemic that were going to help out with COVID areas. Agencia Travel, Enterprise Car Rentals. So that really helped, ignite the fire underneath us for the pandemic. So we grew almost 800% in our hospital acquisition during the past 8 weeks. We grew 2,000% on our provider front over the past 8 weeks, just from those partnerships and the marketing that we're doing during the COVID pandemic.
Perfect. Thank you. Very well.
What specialties do you see having the most need?
It's a great question as well. So prior to the pandemic, we were looking at family medicine being the biggest one, because they can cover both inpatient, outpatient, and ER. Specifically ER physicians, internal medicine physicians, as well as if we're looking at specialties, cardiology and GI were the big ones. During the pandemic, though, we saw a massive increase in the need for care, especially in nursing, as well as pulmonologists on the physician front.
So are you handling nursing as well?
We are handling nursing. That was one of the pivots that we made during COVID. So backing up prior to this, we launched our MVP in late December, opened up our beta testing in early January, had 4 partner hospitals here in Iowa, 80 physicians, and that was our marketing, our go-to strategy with just physicians. With the pandemic, we made the executive decision to open it up to all healthcare providers, everything from nursing assistants to nurses to mid-level providers, as well as physicians, and then make it a free service for the months of March and April. Number one, to shorten that sales cycle for the hospitals, as well as build those long-term strategic partnerships with them, and made it a free service, and then tried to expand nationally. And then we're able to get hospitals and facilities now all the way from California to New York.
Wonderful.
Yeah, I see that you mentioned reaching out to other state hospital associations, but the logo apparently just has Iowa on it. I was wondering if you work just in Iowa or in a larger realm.
No, yeah. So we actually paired up with about 23 state hospital associations. This is just more of an outdated pitch. I gotta have time to go and put in all of the other ones that we're working with.
Okay, thank you.
Hey, John, I just have a comment on really the first part of your pitch. You talked about, the healthcare system having this broken issue. Then you talked about small hospitals closing, and then you talked about that causes death. This is obviously a great problem to solve, but then I'm trying to connect what you're really doing and getting back to the saving lives thing. So I wonder if you'd be better off kind of starting out with a problem that's more immediately tied to the people who are paying you. So the people who are paying you their problem is the closing, right? That they can't find people and they're having to close. Is that accurate, or what's their most immediate problem?
It's they can't find people, so they're having to close. But except that's not the people that pay us. The people that pay us are insurance providers.
Are insurance providers, okay. And why are they paying you?
Because we generate all of our revenue from the reimbursement rates. So we bill payers directly on behalf of the providers that we place.
Okay.
So it's essentially resurrecting private practice on a much larger national scale. So these physicians and nurses would be salaried employees, that they'd be part of a profit sharing incentive. So it'd be putting the autonomy back in their hands, choosing when, where, how often they'd want to be able to work. It's more of a eat what you kill type of model for them.
Mm-hmm. Yeah. Okay. Well, let's talk about that a little more offline and maybe brainstorm a little bit.
Any other questions?
Well, I'm just wondering about how this is going to work, if there's a change in the medical model of insurance being financial aid for people to actually have their health care taken care of. In the society right now, the way we have it in this country is you have to have financial aid in order to get care. What if that changes so that it's a much more equal system for people? So some people might have great insurance and and other people don't, how is this going to change when that changes, if that changes? God, please let it change.
Yeah, no, it's a great question and one that's always on the back of our mind. Um, the interesting part of this model is that regionality plays a big factor into our revenue. So payer mix between private and public insurance, private versus Medicaid, Medicare. So those payer mixes ultimately dictate how much revenue we're going to generate, and then if we have to charge the hospital a subsidy on top of that. So either way, if we move to a nationalized healthcare model where reimbursement rates were to drop, that would just mean that every hospital would pay us a subsidy to at least cover a portion of the provider's base hourly salary.
Well, I'm glad you thought of that ahead of time. Because as a healthcare provider, and I'm alternative because I'm a chiropractor, I have opted not to be part of an insurance system that doesn't serve. So, like for me, the reality is it costs me more to accept insurance as a payment form than it does to have people just pay me what they can.
Yeah.
And, that model of having to have financial aid for healthcare isn't going to stand for much longer, I'm pretty sure, because people are just so tired of paying through the nose all the time. Mm-hmm. And so it's good that you've thought of that, and I would suggest more thinking along those lines as well. So thank you so much for this, though, John.
Thank you. Appreciate the feedback.
So this is a fantastic idea. I kind of wish this had been there about 6 years ago when my wife was in residency and she was doing some moonlighting, and that would have been a fantastic thing to have a few years ago. I'm wondering. So this seems incredibly well put together. At this point, I mean, I know you're going to be working through stuff during the accelerator. So, what's the major thing you hope to get out of the accelerator this summer, and then what do you plan to have as your next steps beyond the accelerator?
That's a great question. For us in the accelerator program, we have been able to, prior to the accelerator, been able to effectively acquire meetings with single entity private hospitals. The biggest challenge for us, though, is that Unity Point, Mercy, and Genesis comprise 80% of the market in Iowa under 3 institutional names, and they control 80 plus hospitals. So the connections and networks that could potentially be leveraged in order to help integrate with those health systems would be our biggest bet.
Nice. And then what are your next steps? What are your next steps then after?
Next steps after that, this is a very interesting thing. So what Greg was referring to, we are currently operating under just that matching business model. Mm-hmm. This new cloud clinic model, it's been difficult to get set up. So it's taken us probably the last 4 months to get a lot of the pieces in play. We are 99% of the way there. We have physicians run all the way through this model that are actually credentialed under our name. We just need to place them in a location that would allow them to work underneath that model. And so we're just looking for the correct opportunity. We've already signed 5 hospitals on a letter of intent to use this model. But the physicians that we have in the system are highly specialized. So we're looking for the correct opportunity for them. So our next step is getting them in there, validating that this model actually works and we can generate money with it. Raise our next round, and then take this model, really expand it up, and then scale into the 5 surrounding states by Iowa.
Any other questions? If I don't hear any, I'll go ahead and ask our traditional final question. What can we as the community do to help you?
if you have any connections to health hospitals that we don't already have partnerships with, any introductions would be greatly appreciated. We have a decent cold email conversion. However, that whole process gets sped up significantly with any outside help or any leads into a hospital. So we'd really appreciate that.
Very nice. And how do we get in touch with you after our event today?
So all my contact information is on our website, which is just apollohct.com, and I can drop that in the chat as well.
Perfect. Excellent. Well, thank you very much.